Hello, and thank you for joining Sessions 3B, Building Strong Collaboration Between Housing and Services. You are in the Improving Services track. My name is Joe. I will be your producer for this event. Before we get going, I just want to run you through a couple of quick housekeeping slides. These will probably look familiar. This event is being recorded and audio is now broadcasting. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. And now I would like to invite our moderator, Pat Tucker, to take the floor. Pat?
Well, good afternoon or good morning, depending on where you're calling from. Great to be here. Great to have you all here. I wanted to say that, Joe said if you have any questions, to put them in the all questions boxes. I think you're going to have questions. And I want to see them in the all question box because we got two incredible speakers today. One of our speakers is Carol Collard. Her bio that's in your packet doesn't do her justice. She's an amazing woman who is the President and Chief Executive Officer at CaringWorks, and she's been doing this work because it's a passion of hers, and she's done a ton of work. And I'm not going to go into all the details that are in her bio, but only to say her bio doesn't do her justice. And the other person that we have on the phone or on this webinar is Sean Hubert. He's the Chief Housing and Strategy Officer at Central City Concern. And I've heard some incredible things about the work that's happening there. So he's coming to share some of that and information with us. And he's also worked in the field for a long time. He's came to Central City Concern after a decade of managing affordable housing communities in Oregon and Washington. In his current role, he's worked as the Senior Director of Housing, leading efforts to integrate, streamline, and improve housing services and facility operations. So we have two amazing speakers. And I say let's take advantage of having all of this brain in the room, and let's pick those brains, okay? So we're going to get started off with Carol. So Carol, take it away.
Sure. Good afternoon, everyone. As Pat shared, and I want to thank her for that introduction. I hope I can live up to that. But as Pat shared, I am the CEO for CaringWorks, which is a Georgia-based nonprofit organization. We specialize in providing supportive housing. We also provide comprehensive behavioral health services. And currently, we support over 400 apartments across the metropolitan area. We provide services that enable us to offer individuals social supports or wraparound services, as well as I shared the behavioral health and psychiatric services that some of our clients need. In addition to that, we engage in a lot of collaboration with other providers in our community to support our clients with educational support, spiritual support, legal support, primary care or medical supports, and just basically fill in the gaps in the areas where we do not provide services. Another area that's important to us in terms of working with our clients is an area that we call community or civic engagement. And so we hopefully try to offer a holistic array or menu of services to assist our clients in experiencing a life of dignity and independence. Just to tell you a little bit about how we operate in the metropolitan Atlanta area, we are, of course, receiving HUD funding for a lot of the services that we provide, the housing supports that we provide, and so we operate under a coordinated entry process. So referrals come to us through those coordinated entry access points, and there's one for each continuum of care in our metropolitan area. In addition to the permanent housing that we offer, I should make a note that we have a residential addiction treatment program which houses 70 men at any given time. It is an all-male facility. The criteria is that you must obviously be seeking recovery and you must be experiencing homelessness upon entry. Embedded in that program is a program specifically targeted for deaf and hard of hearing adult males that we serve and provide similar culturally competent services. Okay, Sean, you get to tell your part.
Thank you, and good afternoon, everyone. So CCC is a nonprofit organization in Portland, Oregon, and we're dedicated to ending homelessness and advancing overall health, financial resiliency, and social connectedness. We've been around since about 1979, and what makes us a little unique is that we're both an affordable housing provider, but we're also a FQHC, or Federally Qualified Healthcare Center for the Homeless. So at CCC, we look at the intersectionality of homelessness with other social, structural, and systemic issues, and really try to develop a holistic approach. So we look at both sort of the structural factors as well as individual factors that together really create and perpetuate homelessness. And so we really are set up in terms of our strategies. We try to develop strategies that respond to both of those. So on the structural side, when you're looking at things like poverty, scarcity of affordable housing, cuts to benefits, racism bias, those sorts of things, we really focus on improving systems and public response systems, as well as looking at what the community resources are or lack thereof, and really focused on sort of policy and advocacy work as well as community development. But obviously on the individual side, when you're dealing with things like poverty, mental health conditions, adverse childhood experiences, addictions, et cetera, that's really where we obviously have been focused for a long time on a comprehensive continuum of services that really address that, with a particular focus on social connectedness, which we think is sort of a missing link in terms of the long-term stability and resiliency of the populations that we're dealing with. So here you can see these are sort of four main dimensions of our work. Direct access to housing, which supports lifestyle change. We've got about 2,200 units, and that spans transitional and permanent housing options. Integrated healthcare services that are effective in engaging people that are alienated from mainstream systems. And this includes things like primary care, mental health care, both inpatient and outpatient treatment services. We also do a wide range of employment and benefits acquisition work, and this is sort of grounded in an evidence-based supported employment model. And then sort of lastly, again, around the social connectedness, we really are focused on the peer delivery of services in a way that supports personal transformation and recovery. This is just a quick look at the housing portfolio. We do a lot of more sort of standard affordable housing, everything from PSH to workforce. And then we also do a lot of very highly programmed and highly specific housing for populations such as reentry and diversion, a lot of recovery, mental health, that sort of activity. The thing I wanted to sort of focus on, and you'll hear me talk about this more as we go through the conversation today, is we're increasingly moving to population-based care models. And this is grounded in a life course framework, And so when you think about, we all are moving from obviously younger and healthier to older and more medically complex, but within that you start to see that there are populations that start to hang together statistically. So for instance, a population that's primary issues are medical conditions with an opioid use disorder, the interventions that are needed are a little bit different, let's say, than a population that is younger and whose primary issues are trauma and depression. And the last thing that I'll note here is when you start looking at different populations, they also have different risk profiles. So some populations are more at risk of housing instability, while other populations are more at risk of hospitalization or that sort of thing. And so that understanding that enables you to adjust the intensity of your service delivery for those populations. Okay, Carol, I think back to you.
Thank you. I believe Pat was going to set the tone for this.
Yes. So we have some questions for both Carol and Sean to answer. So the first question is, what are important points of collaboration within your organization?
So for CaringWorks, let me get us to the correct slide. Sorry about that. For CaringWorks, our main domain are the top 3 items that you see here. I looked at just the range of needs of clients and the types of services that would be offered to address them. And using our organization as an example, out of the 7 domains in terms of the types of services that folks would need, we directly provided or provide 3 of those, and that would be the first 3: housing, case management, and behavioral health. As Sean will later allude to, conceivably any one or an organization could provide all 7. In Georgia, typically the organizations that are able to do that are what we call community service boards. They are typically funded or largely funded by the state behavioral health services agency. For a nonprofit like CaringWorks, the first 3 or the first 2 are actually more common from providers in our community. And so having said all that, when you look at the list, there are opportunities for both inter and intra collaboration within the organization and external to the organization. So what makes collaboration, whether you're working within a single organization to have all of those client needs met, or you're working in partnership with other entities external to your organization, is that we've got to make sure that our objectives, what we want to accomplish, aligns with each group. Even within, and I've had this experience over the years, even within a single organization, this is a conversation that cannot be missed in terms of making sure that everybody at the table has the same end goal in terms of how they want to assist the client. And creating open lines of communication also speaks to having a measure of trust within an organization or within partners. And at the end of the day, our focus, our collective focus, needs to be on the clients that we serve. When this works best, when it comes together in the way that we all want it to be, is when everybody at the table is doing their job and doing it well, that we are clear about the roles that each of us has. The clearly defined roles become more challenging within an organization more often than not than when you're collaborating with another partner. Clear policies and protocols and clear channels of communication. Communication, of course, we can't ever take that for granted in terms of how important it is to make sure that all players are aware of what client needs are, what their individual roles are, and how we're going to work together to get the job done. You know, obviously the benefits when we are successful in bringing all of this together is that we are able to take advantage of the resources that exist in the community. You know, as much as I am a control freak, and I recognize that CaringWorks cannot and should not do everything. And so it's incumbent upon us for us to work collaboratively with other partners in the community, those that already have achieved a level of competence and a reputation for doing good work, and for us to work together to provide the needs or to meet the needs of the folks we serve. Where it becomes a challenge is if we discover in the midst of working together that we have differing philosophical outlooks about how services should be delivered and, quite frankly, who we're serving. Different competency levels among staff. I don't have control when I'm working with other partners of who they hire. So those are things that we have to remain vigilant about, be aware of in terms of how it may pose a challenge when working together. And of course, making sure that the differing corporate cultures are complementary. The things that you want to remember, of course, is that there has to be a primary partner, a lead agency, if you will, whether that's the housing provider or the provider of the behavioral health services. Often is determined by who is initiating the program and the collaboration. But we need to make sure that there is routine communication from that body, and that we are all consistent in understanding the policies and the protocols to make the relationship work. Sean?
Thank you. So I was going to talk a little bit here about collaboration within an organization. And I mentioned that, you know, we are moving towards team-based models of care. And you can see that represented here on the slide, where we're focused about putting a population in the center of the services and then bringing the right services around that. And so really this team-based model of care, you know, that traditionally, you know, the supportive housing staff reports up a certain chain and the employment staff reports up a certain chain. So this question of how do you structure something like this organizationally, and how do you approach this collaboratively has really made us sort of think differently about how we do this work. And again, what we're trying to do is to intentionally match housing programs and services to well-described populations here. So part of this, I think, is just making sure that you are able to reflect visually how you're structuring an approach. And so this, for example, is the representation of a building. And we've sort of, you know, we've color-coded this so that it's easy for teams to understand how we're going to sort of place people in a building. And so, for instance, above the red line, about halfway up the building here, you can see this is our housing floors, and the green would be permanent housing, and the tan is transitional. And then the purple and blue are actually, we have some palliative units and then some recuperative units as well. And then below that, on the service side, is where there are pharmacy and acupuncture and treatment and primary care type services. And so, you know, we've moved to a place where we're intentionally programming the buildings really around this concept. And again, this means that we're approaching sort of intentionally setting up care teams that are really organized around intensity, excuse me, intensity of care. And when you look at the service framework here, Typically that means there's 4 different intensities that we are programming around. One is all client services, things like pharmacy or acupuncture employment services that are really meant to be accessible by anyone that is attached to the building or is attached to services in the building. But then you get into basic services, intensive services, and complex care, where there are different levels of, say, treatment or different levels of behavioral or mental health care that are attached to those service teams. In terms of how we actually get people into our services, we've had to rethink that as well. And we've set up a whole team that is really around a centralized intake and service matching process to make sure that that team can become sort of a best practice around getting people to the right care. And this is sort of shows how we walk people through a centralized registration and then a service matching process where actually there is a peer that's working with them on doing that service matching, and then ultimately that gets them placed into the right sort of population team. And how this actually looks in practice, this is an org chart of a site. And you can see up top we have a director of the center that is primarily focused on things like the overall financial performance of the site, et cetera. At the bottom, you can see in sort of the blue, or sort of the violet, is we still have service line leadership. So this is a matrixed structure. And so we still have service leaders that are overseeing, say, housing or employment or behavioral health, making sure that those practices are using evidence-based practices within those service lines. And then on the left, we have in green, we have actually our integration lead. And the integration lead, you can see, sort of is overseeing the care teams, basic services, intensive services, complex services. And that integration lead is really focused on the delivery of care, the evolution of the care model, and really making sure that our outcomes are strong. And so what you end up having is sort of a 3-party leadership structure where the director, the service line leaders, and the care team lead really are coordinated around both the financial performance of a site as well as the delivery of care. And lastly, I'll just sort of highlight that one of the tools that helps support something like this is we do a lot of process mapping. And so this just sort of shows the process that someone will go through when they first walk through a door to when they get placed with a service team. And one of the things that this does is it really supports, how you do ongoing quality monitoring and performance improvement, but also really becomes a good tool in terms of how you onboard and train staff so that you get a really consistent delivery of services that everyone sort of understands and is bought into.
All right. Thank you both. So far, we're having a good time here. So we're going to open up the floor for questions, and we have some questions. Please keep them coming. But one of the questions is, how can shelters overcome issues related to male and female interactions of clients? The only shelters in my town will no longer accept women due to this fact, which is very sad, because it often creates an issue with the children. So it sounds like there's some issues going on with maybe not enough shelters. So collaborating and finding partners to deal with this issue. Either of you have any thoughts?
We do operate at CCC a couple of dormitory-style housing programs, but we are not a shelter provider per se. But I can say that either at CCC or in our community, we tend to have 4 different types of shelters, and so we do have shelters for men or women. We do have shelters for couples and or families, and so I think in that environment, everyone that is in that shelter is part of a couple and or has kids, and so you can really focus on again people in that household arrangement. And then we do have a few shelters that are really gender neutral and that tries to be welcoming for people of all genders. And I think having those four basic types of living arrangements does allow you to start to develop some specific programming and supports, as well as appropriate, sort of ground rules and those sorts of things within those environments. And so we've found that approach to be fairly successful. And then it really becomes part of a sort of a housing choice for the clients, where they can sort of be part of the process of determining which environment is going to feel better for them.
Great, thank you. Did you want to add anything, Carol, or should I move to the next question?
I think in the interest of time, we can move on.
Okay, so how do you encourage collaboration and a buy-in from potential network organizations that has historically walled themselves up from others? Yes, it's a good question, because there's some agencies that try to do everything within their agency and don't want to partner or don't want to collaborate, but it might be a good fit. So how do you bridge that gap, or how do you even start that conversation?
Yeah, and I will defer to Sean if he's got a reply, because I think the challenge for us here is the majority of the providers in the Atlanta area, or I should say in the metropolitan Atlanta area, are HUD funded and have to abide by, the same regulations as it relates to coordinated entry. So it's become smarter for us to choose to collaborate. And even without that as a mandate, I think historically we've been kind of lucky in choosing independently to work with each other. The challenges become more present when you get outside of that the city limits, if you will, and you get into the more suburban-based continua, where there's more faith-based organizations, and often the challenge, they have more independence, if you will, and are not as eager to partner with organizations that do have to abide by HUD regs. But I think we have done a really good job of information sharing, particularly data about what's going on in our community and how people are being served. And we just, on an individual basis, just continue to work with whoever wants to or can work with us. But Sean may have different experiences in his region.
I'm a big believer in relationships and relationship building. And so I think in this kind of a scenario, I found one of three approaches to be successful. I mean, one is really that you're building a direct relationship with the executive director of that organization. The second is that actually you're taking a look, if it's a nonprofit organization, at their board of directors and seeing if there's any connections within your organization's circle, either staff, leadership, board of directors, with one or more people on that organization's board of directors, and start a conversation at a higher level around partnership there. And then lastly is looking at other community partners, typically funders. We have both city, county, and then a lot of philanthropic funding organizations here in the Northwest. and typically having one of those organizations actually do the outreach to the other party if nothing else is working, and starting to suggest a collaboration from that lens can be successful. So usually, we'll take a look at one of those three relational sort of routes if we've not been successful elsewhere.
Excellent. Thank you both for that. We have another question. I am pretty familiar with Central City Concern, but would like to hear more from both presenters about housing and services for justice-involved individuals, including veterans, and the best practices that are working well with those populations. So I think they want to hear a little bit more about the work you're doing.
Sure. So for Caring Works in Georgia, in the metropolitan Atlanta area, all of those subpopulations are prevalent in amongst the folks that we serve. We have had the benefit of securing funding to provide services specifically for veterans. There are HOPWA dollars in the community that are distributed to providers such as ourselves so that we can do permanent supportive housing and other wraparound services for individuals experiencing HIV and AIDS. So there are subpopulations. I think for us what is probably more prevalent here than maybe in other metropolitan areas is that we also have support of the state to serve deaf and hard of hearing clients. And we are doing that initially with, as I mentioned before, our residential treatment program for SUDs. And also, of course, once they have completed the program and graduated, in assisting them to secure permanent housing.
So at CCC, we do a lot of work in this space, and typically our work falls into one of three areas: either diversion from jails, and we do both a LEAD program as well as a housing rapid response program, and really we're looking to divert people that would otherwise be going into the criminal justice system. We also do sort of some harm reduction programs that are really working with people that are on the street and engaged in sort of low-level but high-frequency criminal activity, and the goal of those programs is really just a reduction in the level of criminality with people that we're serving. And then lastly, we do a lot of work on the reentry side. And I'll say with the reentry side, I think one of the things that we've really learned is the more that you can do in reach before someone is released into the prison system, where you've got peers with lived experience that are building relationships with individuals that are about to be released, that are already building sort of housing and employment and service strategies, and they're making sure that they are landing well in the program. And if there's anything else needed, like treatment services, medication-assisted treatment services, things like that, that those are all queued up and ready to go. So that in-reach is a very successful component of the reentry work. And then I will also say that we found employment services, I mean, a lot of the issues that this population faces are frankly discrimination around employment opportunities. So if you're able to build employment practices really targeted around this population that are effective, that is really going to help the overall housing stability rate, the recidivism rate, and other things that funders of these types of programs really care about. So we feel that early engagement and employment services is also critical as well.
Thank you. And we'll move to the next slide. We're going to keep the questions coming. We're going to get to them, but keep putting them in the all questions box. What are some ways to establish collaborative relationships between agencies?
So I was, oh, sorry.
I believe it,
no,
go ahead, Carol. It's you, Carol.
Yeah, I'm sorry. I wanted to give him the opportunity. So for us, as I shared earlier, our main focus has to do with securing the housing, providing the wraparound and case management services, and also providing behavioral health. One of the other needs for many of our clients, of course, in addition to that, is being able to secure a reliable source of income. And so we are highly motivated to identify partners in our community that will assist us in getting our clients either SSI benefits and other similar income-based benefits, or if they are able, employment. And so in our neck of the woods, there's an organization called First Step that does both. They have a SOAR program that they operate to help individuals secure SSI benefits, and they also are an employment agency. And for many of those opportunities, it's a temp to hire circumstance. And so over the last, I would say 7-8 years, we've been successful in partnering with First Step. So in terms of identifying client needs, we wanted to make sure that we were clear in terms that in this particular case, it's very clear in terms of the different roles that we would bring to the table, but it was very important for us to also itemize that in a document that we could to institutionalize the relationship. And so we have engaged with them over these several years with a memorandum of understanding. We have worked together to secure grant funding. They have on their team a dedicated staff person to work with our clients as we refer them to either be assessed for their SSI benefits or, of course, to get referred for employment opportunities. Out of this experience and also working with a variety of partners over the last 17 years is just taking that time initially, and it's, referencing actually something Sean mentioned earlier in terms of developing those one-on-one relationships with agencies. And out of that encounter, it's very important for the respective parties to have some sense of the values, the corporate values, and the culture of the entity that they are seeking partnership with. And again, making sure that we are clear on what our objectives are, what the end game is that we envision for this relationship, and a way to monitor whether or not we're actually achieving the goals that we set forth with one another. And lastly, I would say, and I put on here a little tongue-in-cheek, is to be okay with, with imperfection. And there's not going to be a perfect partner relationship. There's no perfect agency, but as long as you are willing to communicate and to work together, you should have a satisfactory relationship.
All right, Sean, sorry. I'm turning it over to you.
Thank you. So I thought I would talk about one of our collective impact projects called Wheelhouse. And this, like a lot of partnerships, this kind of a project has definitely had its challenges, but I think it provides an interesting framework for how you can go about pretty significant community collaborations. And so this Wheelhouse collaboration was really about expanding recovery options in the Tri-County metropolitan area here in Portland. And it really was focused on this issue you can see in the upper left-hand corner that only 1 in 10 individuals is receiving treatment for opioid use disorder. So it's really looking at, in Oregon, we have one of the lowest rates in the nation of people with an addiction that are engaged in treatment. And this is really a kind of a big community-wide collaboration to see, if we could impact that. And the goal was really to expand access to medication-assisted treatment and to help more organizations, more community-based organizations become proficient in providing those services. And so this was really a hub and spoke model where the community hub, you had 2 organizations, Central City Concern and CODA, come together to provide some of the technical expertise and support. And then you had spoke members as well as housing partners. And so you had both referral of clients from hubs to spoke as well as the ongoing technical support. And you can see that they're sort of broken out and spoke into Tier 1, Tier 2, and Tier 3. Really there was an induction pathway, a stabilization, and then a maintenance. So basically as populations increased in their recovery stability, they would go from Tier 1 to Tier 2 to Tier 3. And the intensity of services goes down as you move up those spokes. And so again, the hub partners were CODA and CCC, but also a local coordinated care organization, Health Share of Oregon, that was the primary funder behind this initiative. And Health Share is the state's largest Medicaid coordinated care organization. And then there was actually a pretty wide variety of community-based spoke partners in this, including the ones you see listed here, which span culturally responsive mental health and addiction service providers, behavioral health and housing agencies, and treatment providers as well. And, so the process really was that the funding came from the coordinated care organizations, and then the spoke organizations really started with an underlying organizational assessment in terms of really what their needs were, what their capacity and cultures were, and what would need to kind of shift to integrate MAT into their programs. And then the hub partners helped to support that work with technical and clinical supports. And part of this was building a community-based model where you came to an understanding as a community what the different tiers were, what kinds of services and competencies and capabilities really needed to exist in these different tiers. And then the goal was really to help organizations, to help more community-based organizations, let's say from going only able to provide, say, Tier 3 services to maybe also being able to provide Tier 2 services or even maybe Tier 1 as well. So it was really the development of a shared understanding of competencies that were needed in the community, and then sort of a strategy to help more organizations increase their competency levels. I will turn it back over.
Thank you. So we have some questions. I'm liking this questions coming in. One person had a question about what's a good way to start that relationship piece. Do you do coffee? Do you meet up? Do you do a phone call? Do you brainstorm? How do you get that started?
I'm happy to jump in and
go for it.
And then Carol, if you want to follow up, I typically like to start with a coffee conversation, and then progress into a second meeting where you're getting thought leaders and sort of innovation leaders from within the two respective organizations to a table. So you're starting to enlarge from that initial, typically two-person conversation. you're starting to enlarge the conversation with what I think of as influencers from within both organizations. And so I think one of the things that's important is obviously knowing who your innovators, thought leaders, and influencers are within your organization, but also working with the partner organization to kind of talk through the kinds of capabilities and thought leaders that you want to invite into the conversation. And then so you're starting to build, again, a little bit of a broader base of support and some excitement, hopefully if you do it right, in the early partnership exploration stages.
Yeah, that sounds compatible with what I would have said.
I'm going to take liberty to add a little bit to it. I think events like this one and other events that are in your community where if you know that one of your needs is, say, an employment program, finding out, where they have in their meetings. See if you can get to the meeting to start meeting people at the employment group, and start handing out your business cards and start talking to people about what they're doing and who they're working with and who you're working with. And I think that's a great way to get that started. But it's getting out there and meeting people and starting to talk about your programs. And I think that works really well.
You're bringing up an important point because we have a pretty routine forum where all providers get together. I would have imagined that would be similar in other areas where the continuum of care, the providers in each respective continuum of care have routine meetings which provide opportunities for networking and introductions and things of that nature.
Great. So the questions keep coming. And this one is specifically for you, Sean. People are really liking your program. So this question is about the ratios for staff to residents from your previous design from CCC. So what are your ratios for staff to residents?
That's an excellent question. We typically, we typically are in about sort of the 1 to 20 ratio. Our most intensive program is at a 1 to 8 ratio, and then I would say, we do have a couple of sites that again are really permanent housing for people that have successfully transitioned, typically from our or other sort of transitional supports within the community, and are fairly stable. And in some of those situations, we have a 1 to 50, 1 to 60 kind of a ratio. But I would say in a typical program, we're right around a 1 to 20. Although again, there is some flexibility there depending on the intensity of the services and the population being served.
Another question that is coming up, and it's for you, Sean, but I think, Carol, you may also have something to add. I would like to learn more about CCC's collaboration with local hospitals in developing housing. How were you successful in getting them to think seriously about it, and how is it going?
I will, if I could pause on that question, I am covering that in the next presentation.
Okay, great. I thought so, but I think everybody's interested in this, getting the hospitals to the table. So we'll go to that question in a little bit. Excellent. Let me see. There are so many questions that are coming through. So the next question is about making the process work for the clients. So how do you ensure that, developing these partnerships is going to work for your client?
Well, if I'm understanding the question correctly, for us, we routinely interact with our clients to assess client needs, not just what staff thinks that the client needs, but also to ask clients directly in terms of what their needs are. And from there, that information is reviewed and analyzed, and that informs what services we feel that we can provide directly or what partners we need to identify in order to meet those objectives.
Okay. Sean, anything to add?
I would just echo that. One of the things, obviously we're always looking at the outcomes, the program outcomes, to make sure that they are at or better than sort of what the benchmark is. But I think more importantly, we typically every 6 to 8 months are doing client and resident surveys and really trying to understand what the client experience is. And particularly in, sort of third-party partnership scenarios, that's, where you don't have as much visibility into all the activity that's occurring. Surveying the clients and surveying their experience really helps you understand maybe if there's something that needs in a partnership that needs to be tightened. So I would echo Carol's comments.
Okay.
Yeah, and I
have one. Go ahead.
I was just going to add, I think the client survey, because we do that as well, is very important. And I'm sure for Sean's group, we also engage a third party to do that, because I want clients to be able to speak freely, favorably or non-favorably. And if it's their case manager asking the question always, sometimes they don't have the freedom to criticize, right? So it's we can only afford to do it annually. So I like the 6 to 8 months, because I think there are nuances that we should or I would love to be able to capture. But it's important to me we do surveys and focus groups that would be done by a neutral party.
Great. I'm going to throw out one last question before we jump into the next part of the discussion, and that's the involvement of peers in the collaboration process. How do we get the peers involved in collaboration? Or is there a place for the peers in collaboration?
That's a good question. On the internal level, certainly, we have a number of peers on staff, and Sean will elaborate, but I think for us it's more helping us to identify client needs, to identify opportunities for collaboration. What would you say, Sean?
We're getting a lot of good questions here. I think it's twofold. One is, I think, just as an organization goes through and sort of develops its strategic, plan and strategic vision for the next period of time, I think you want to make sure that you've got a robust engagement process that really gets staff from all levels engaged in sort of talking about what the organizational challenges and what the organizational opportunities really are. And I think making sure particularly that you have good representation from your peer staff in setting that organizational strategy and vision and sort of helping to sort of think about the work of an organization in the next couple of years is really critical. And then secondly, I think whenever you're talking about program design, and particularly program design that involves a collaboration between 2 or more organizations, I think making sure that you've got some of your peer leaders involved in the aspects of program design is really critical.
Thank you. Okay, so what organizational policies and strategies help build strong relationships with community organizations and landlords?
So here, I thought I would talk about the Housing is Health initiative, which I think responds a little bit to the question that was asked about the health system involvement. So our Housing is Health initiative saw 6 health systems invest $21.5 million in 3 CCC projects that you can see on the screen. They were represented 380 units of housing and a integrated health clinic. And so here are the 6 different health systems that invested in these projects. And I like this quote from Dave Underreiner, who is the CEO of one of the health systems. We know that access to housing helps stabilize people's lives and puts them in a better position to get the best level of care to keep them well. So, you know, everything starts obviously with relationships, and relationships are built on trust, understanding, and experience. So I think it's really important, you know, it's really important to start small on some of these. And so I think starting with pilots is a great way to start building relationships. And, you know, for us, we started a small pilot in 2005 called the Recuperative Care Program. And this was really aimed at helping hospital systems with this quandary of what to do with people that were homeless and in a very expensive hospital bed. And if they discharged them, they were likely to be readmitted with the same issue that would be unresolved within a 30-day period of time. And so we started a small pilot where we provided housing and then the follow-up primary care that was needed. And we saw that readmission rate drop from about 60% to about 6%. And so that really both build an understanding between our organization and health systems around understanding housing as a health intervention, but it also provided a data bank, really, that as the hospitals invested in this and they saw the results of it, really supported future investment and ultimately, you know, the expansion of that program. So I think pilots are a critical way of building relationships and building understanding and experience together. Secondly, I think really looking at board recruitment is really critical. You know, we work to get 3 executives from health systems on our board of directors, and that really helped get or enabled there to be a better understanding of our organization and the work that we were doing, and what the sort of potential really was for collaboration. Secondly, or thirdly, I would suggest exploring intersectional opportunities. You know, we were able to get our executive director onto the Health Share of Oregon board, and that both enabled us to continue to bring in housing conversations into what traditionally had been a healthcare space, but also enabled us to have a better vantage on what the priorities and what the pain points and what the concerns were of the health systems. And then we were also involved in a number of smaller sort of community collaborations. And so I think it's a good investment of leadership time to be on the sort of community panels where you are building relationships and sharing learnings and sharing experiences. And then lastly, and I can't stress this enough, it's really looking to secure and build champions. And so, you know, I think as we're engaging with health systems, there were a couple of CEOs in particular that were really engaged in the conversation. And so I think, you know, we really spent a lot of time making sure we answered their questions, inviting them on tours of our facilities and operations, and really built champions there that then, you know, they were able to then take the message and sort of call other health system CEOs to a table to sort of convene a conversation. And if you don't have some champions in whatever space that you're looking to engage in, it's very difficult to get traction. So I would say these are really critical elements to how to go about building these types of relationships. And then I would also note, you know, really understanding the type of partners that you're looking to engage with, really where their needs and pain points are. You know, this slide reflects the results of a community health needs assessment that hospital systems, you know, conduct. And you can see here housing, you know, rises as the #1 need there. But I think, you know, we read through all of the community needs assessments and are understanding pain points, and then are able to sort of engage in conversations and dialogues with these partners, not necessarily just from your perspective, but also their perspective, and understanding where there are intersections and opportunities for dialogue and collaboration. I also think framing the opportunity is really critical. So this map of Portland is a heat map where we loaded our data that was data of the last known zip code before admission into our detox center, which sees about 3,000 homeless individuals a year. And you can see where the darker orange color is. That is where the highest need is. And where the star is where this opportunity for one of our large investments was. And so when we were able to sit down with them and actually show them the data and say, hey, here's where the need is. This is where people that are high-cost patients in your health systems are living and coming from. And what we want to do is to put a really catalytic investment right in the middle of this need. That's a compelling argument. So I think really making sure that you're able to frame the opportunity, with good data is pretty critical. And lastly, I think we all need to sort of know our audience. And as part of our conversation with the health systems, we wanted to make sure, and we understood that ongoing monitoring and learning from this kind of a collaboration was going to be really valuable and really important to our health system partners. So we brought the Center for Outcomes and Research into this, and really knew that that this ability to sort of be able to track and learn from investments was really going to be a key priority. So I think I think you've got to both sort of appeal to the heart as well as satisfy the number crunchers when you are trying to make a pitch like this. Carol, back to you.
Sure, thank you. Most of my remarks in this section have to do with establishing relationships with landlords. As we are a supportive housing provider, we pay rent on behalf of our clients, and we work in partnership with property owners, property management companies across the metropolitan Atlanta area on their behalf. And relationships are important in this context for obvious reasons. We have, like I said, been doing this for the last 17 years, and what I find that it's easier for us to identify and secure housing when the economy is not great, right? They're very eager for you to engage, secure units, because they're having on their own difficulty in leasing their apartments. When the economy is much better, they're not that interested in working with, quote, our kinds of clients. And so it's really important for us to identify property owners, get them to understand the full dimension of our clients' experience, for them to be able to trust and rely on the value that we bring to the table in serving and providing services to our clients. And one of the things that we try to do, and we have done it formally in terms of having training sessions and informally in working with property owners one-on-one, is doing kind of a mental health 101 training for them. Getting them to understand, when clients' behaviors are not directed at you or your staff personally, it's part of their condition, part of their illness. So important to any provider working with a property owner is to know fair housing laws, know when it is appropriate for a landlord to turn away a client. Be clear about the eligibility. There's a threshold in terms of regulations in each area, but there's also federal law that we need to be aware of that protects certain rights of our clients. The other thing that I would share, if you are aware that you, whether it's 1 or 30 clients in a particular housing development, that you can establish eligibility criteria for your program, for your supportive housing program, that may introduce more relaxed policies, say around employment or credit history, and even to a certain limited extent, criminal background. This is acceptable in a fair housing arena if your clients are participating in a program and are identified and distinguished as such. The importance of having that relationship and educating the property owners and the landlord helps not only your client have a successful housing experience, but in the larger sense also helps to reduce the stigma that's attached to mental illness and other behavioral health conditions.
Wow, you both have some amazing programs and amazing agencies. We got some more questions, so let's get to them. One question is, how can I get an organization involved in collaboration who don't see homelessness as part of their work? And I think this could go back to the 2 examples that we just had, both the hospitals and the landlords. I think those are 2 examples, but how do you do that? I mean, how did you get them to the table and get to a point where they could see it as part of their work?
So I think focusing on what it is that you need from them, I think if we spend, and I may be misinterpreting the question, but I think at the end of the day, we don't want any of our clients to be primarily identified because of their homeless status, right? And so what are the needs that those individual clients have? What does this partner bring to the table? And we focus on that.
And John, anything to add?
Well, and without knowing obviously sort of what this particular partner or potential partner does, I would say that homelessness usually, when you dig at it a little bit, it has so many different impacts in terms of everything from the business community to the fact that if we're not making the right kinds of investments, we end up spending a lot of public money unwisely, and whether it's in, jail or, first responders or whatever the case is, health system costs. And so usually, if you're able to find the right way of approaching the partner and say, hey, you may or may not be interested directly in homelessness, but homelessness is likely impacting them in some way. And if you're able to maybe frame that conversation in a way that helps get them interested in seeing that there is likely a connection there, I think that's probably the approach that I would try.
Agreed. I think you both have brought out some great points. I think the other thing that I would add to this is trying to figure out, if your clients or tenants are using those services, then there is a connection. And looking at how a collaboration would benefit both parties. I think it's important to realize or think about how is this going to benefit this potential partner. And that's your selling point, is how is this going to benefit them? And how is it going to benefit your agency and also make things easier for your clients is important to keep in mind. I think we have time for one more question. And this one is, how can funders encourage cross-sector collaboration in communities where housers and service providers do not have strong existing connections?
You know, people, I mean, you know, funders, you know, funders typically carry a lot of water, and I think quite frequently they maybe don't use their you know, their sort of power of the purse, if you will, you know, maybe as effectively as they could, particularly when it comes to encouraging collaborations. You know, here in Oregon, we have a couple of philanthropic funders that part of how they put out you know, RFPs, you know, for funding awards is, you know, they require, for instance, collaboration, or they value or score collaboration highly in terms of how they make their funding allocation decisions. And so, you know, I do think that, you know, typically we're all, probably most of the organizations involved in this phone call are dealing with complex issues that are interrelated with other community challenges, and no one organization is going to be able to solve everything. And so I think really, you know, starting with leadership of that other funder and talking about maybe bringing to them ideas of how they could use their authority or how they allocate funds to encourage collaboration, particularly when it helps address you know, sort of more complex issues that are happening within the community, and heighten the level of interventions that are involved in this type of work. I think is a key opportunity. So I would encourage people to engage with their funding partners a little bit more there.
Carol, did you have anything you wanted to add?
No, I think he handled that one very well.
Well, I think this is bringing us to the end. I wanted to personally thank Carol and Sean for presenting. It's an amazing presentation, and thanks to SAMHSA for having this section. I think it was great to hear about two organizations that have figured out how to do some great collaborations. Thanks to everybody for attending, and you will get copies of the presentation or links to the presentations, and also the recordings if you want to review them again or share them at your agency. So I think that would help. There were a lot of questions coming through. I think some of the presentations hit on those questions, hopefully. And I hope that you have something to take away with you and take back to your organization to encourage more collaboration. So thanks, everybody, and have a great day. And keep going to the sessions of, you know, we have some more sessions today and some tomorrow. So we're looking forward to them. Thank you. Bye-bye.
Thank you, guys.